Puma of Chef Clinic and ChefMD in Santa Barbara, California, and welcome to Culinary RX from MedPage Today. Today we'll try to help a patient with early Alzheimer's dementia and address what to eat and what to avoid eating. And the patient is right here. A 70-year-old white woman is brought to her GP by her kids because she's becoming more forgetful and often can't remember specific words. She used to pay her bills independently and enjoyed cooking, but recently received overdue notices from her utility companies and is cooking less often, which she attributes to the loss of ability to, about 6 months ago, to smell the aromas of what she's cooking. She's lost about 2.5 kilograms in the past 6 months. Her kids are concerned, but when they express that concern, she becomes irritable and resists their help. On a past visit to her doc, she had normal lab tests for metabolic, hematologic, and thyroid function, often disordered. Her cardiovascular function appears adequate. Her titers for Lyme disease, ANA, RPR, and HIV, which can cause dementia, all are negative. She's not depressed, and she has a 2 out of 15, however, on the geriatric depression scale short form. And her mini metastatic exam is a 24 out of 30, the MMSE. So she probably has early Alzheimer's dementia. And with us today are Dr. David Perlmutter, here, author of Brainmaker and associate professor at the University of Miami School of Medicine, and Dr. Marwan Sabbagh, who is author of the Alzheimer's Prevention Cookbook and director of the Banner Sun Health Research Institute in Phoenix. Welcome to you both. We have 8 commenters who have addressed this case on medpagetoday.com/culinaryrx, where you can find the case I just read. And they suggest things like a low-fat, whole-food, plant-based diet, a ketogenic diet, an anti-inflammatory diet, fasting for 12 hours on, fasting 12 hours off, avoiding anything eaten that's packaged in plastic, and those are the main suggestions. Thank you very much, SBVDC, by the way, for the neurology reversal of cognitive decline citation. Citations are welcome, as are comments on our site. So, to start us off, Dr. David Perlmutter, author of Brainmaker, just recently out. What should this patient eat, and what should she avoid?
Well, right off the bat, let me say that how incredible it is that we're having this discussion in the first place. I mean, here we are in this sort of venue where we're finally having a discussion about the relevance of food in the treatment of a neurologic condition. And that is, I think for everybody involved today, it's a real epiphany moment. I would say that in recognizing the pivotal role of the process of inflammation in this neurodegenerative condition, as it is in Parkinson's and others, that whatever we can do to reduce that process, i.e. inflammation, is going to be helpful here. And I'd like to be able to bring this patient's hemoglobin A1C down as a marker of glycation of protein in general, and therefore as a marker of reduction of inflammation. And I think the best way to achieve that would be to lower her carbohydrate consumption significantly, while at the same time increase her consumption of good fat. I mean, I think we're all aware of the recent publication demonstrating a significant improvement in various parameters related to dementia as it relates to comparing a Mediterranean diet versus a Mediterranean diet increase in its fat content with either olive oil, 1 liter per week, or nuts. And clearly the diet that was most protective, if you will, with respect to dementia was the diet that had the highest level of fat, and in this case the olive oil, for a number of reasons that hopefully we can discuss. So the broad strokes would be a diet that's rich in nutrients, that's nutrient dense, that has some carbohydrate in the form of fiber, that restricts free sugars, that welcomes back to the table higher levels of good fat, and even, if we can go so far, to the uncharted territory of recognizing the important role of the human microbiome in inflammation, and therefore including in this diet fermented foods like kimchi and kombucha and cultured yogurt, as well as prebiotic foods that contain prebiotic fiber to nurture good bacteria in the gut And those would include things like Jerusalem artichoke, jicama, asparagus, onions, leeks, and dandelion greens to really nurture the good bacteria and reduce inflammation.
Really good. I'll come back with some specific questions about macronutrient composition and how much probiotic and prebiotic and so on. But first, let's hear from Dr. Sabbagh. Marwan, what should this patient eat and what should she avoid?
So I share many of the impressions of Dr. Perlmutter, but I want to say that I really go out of my way to distinguish a symptomatic dementia from a pre-symptomatic dementia, and the data in the literature kind of clearly diverge on this particular topic. In fact, treatment diets, prescriptive diets for Alzheimer's disease, specifically in the dementia phase, are pretty weak. There's not a lot of robust evidence that they have benefit. There is some evidence, there's actually research studies going on, that ketogenic diets, diets that are higher in fat, may be beneficial because the ketogenic state will avoid insulin-sensitive pathways as potential treatments for Alzheimer's disease, and NIH is actually investing in a research study for that right now. But overall, the data around specific prescriptive diets to treat Alzheimer's disease are not as strong as we'd like them to be.
Okay, but she's still in our office. We still have to treat her. What should she eat?
I would go for a ketogenic type diet, higher in fat and lower in carbohydrates, in trying to induce a ketotic state. We do know that such diets have been beneficial in other neurological conditions such as epilepsy. So there's clearly a precedent for doing this kind of thing in neurological diseases, and a diet that was heavy on the ketotic spectrum would be a preferred approach.
Okay, so I'm going to describe a ketogenic diet, and then I'm going to ask David if he agrees.
I think, if I may, that we are saying the same thing. I think where we disagree, and we've disagreed in the past, is the validity from at least a research perspective of a diet that is interventional at this stage of the game versus a dietary recommendation for someone who may not specifically carry a diagnosis that is either pre-symptomatic or at least at risk by virtue of his or her family issues. And I tend to take that a little bit more aggressively in recognizing that the diet that we've already discussed is a good diet for health in general.
Agreed.
And that if it's a diet that's good for the brain in general, it is a diet that I recommend across the board to virtually everyone because that's a good diet. And in considering those individuals at risk for Alzheimer's, like myself, by virtue of family issues, I think it makes sense to do what is best for the brain globally. And to me, I worry less about the fact that there have been clinical interventional trials demonstrating efficacy. So I'm in a place in my life where I'm comfortable with the fact that I think we understand the physiology of what happens when people eat this, consume these types of foods, and it's good for the brain, therefore I push for it. Now, the idea of being preemptive or at least preventative, I think is supported by, for example, the New England Journal of Medicine article that was in August of 2013 that demonstrated that fasting blood sugar, even at the so-called normal levels, is predictive of cognitive decline, of dementia risk. And that said, my mission in dealing with patients is to do everything I can to keep their blood sugars low. And again, it gets back to this discussion of a very lower carbohydrate, a much lower carbohydrate diet with added fats, and particularly adding in those fats that will help to promote a low level of ketosis. We as physicians have been schooled to fear ketosis, and ever since that call during our internship of a patient in the ER with diabetic ketoacidosis, we've all freaked out with respect to the notion of ketosis. Turns out that a low level of ketosis is a good thing for the brain, it's a good thing for the body, and it's probably the physiologic conditions that humans have existed in for a couple of million years. So I think
so the notion of what exactly those foods are. I mean, we're talking then 50 grams of carbohydrates or less daily. We're talking from both of you a relatively high fat, either unsaturated or saturated. Olive oil is primarily unsaturated. Coconut, of course, is primarily saturated. Most animal fats are primarily saturated, although lard, interestingly, is more unsaturated than saturated. And an anti-inflammatory spectrum, which means basically brightly colored fruits and vegetables, grains when they occur as whole grains, lots of nuts and seeds, without a lot of refinement. Does that fit the kind of ketogenic diet that you had in mind, Dr. Sabbagh?
Yes, so I am very careful to separate a pre-symptomatic from a symptomatic phase. This is where Dr. Perlmutter and I have disagreed in the past. In a pre-symptomatic phase, I am strongly advocating a Mediterranean-style diet, a diet low in saturated fat, high on the monounsaturated fats, and the study that Dr. Perlmutter is quoting is in the pre-symptomatic phase, so the nuts and the olive oil strongly lend themselves toward a brain-healthy approach, not in the symptomatic phase. But in the symptomatic phase of the dementia, we know that there's some neuronal breakdown and insulin resistance occurring in the brains of people with Alzheimer's disease, and therefore, by extension, we want to bypass insulin-sensitive pathways, and that's why a ketogenic diet in the symptomatic phase makes more sense.
Would you say this lady is in her symptomatic phase, in a symptomatic phase?
That's correct. Once she shows what you've diagnosed early stage Alzheimer's dementia, even into the mild cognitive impairment stage, I think you would find that we would call that early symptomatic dementia or early symptomatic disease.
Do you agree, David?
No, respectfully, I don't agree. I mean, I think that it's quite clear that the changes that take place, at least from a pathological perspective, can be occurring 30 years early on before patients demonstrate significant symptomatology. So I think that the idea of symptomatic versus non-symptomatic, a kind of a binary approach to the diagnosis and treatment of Alzheimer's, that doesn't work for me. I'm more of an analog kind of guy in recognizing that the use of symptomatic versus asymptomatic is really based upon the sensitivity and the interpretation of our testing. And, you know, at many stages of life, we begin to have issues that may very well portend to more severe issues down the line. And as John Kennedy said in his inaugural address, the time to fix the root is when the sun is shining. In my opinion, not when the mini-mental status test is already at 24.
Agreed. Completely agreed.
Okay, because and actually both agree about the patient, which is, of course, the common denominator. Because a patient that's early Alzheimer's is symptomatic. What we've been discussing is differences to a pre-symptomatic approach, and we could explore that more thoroughly. But for this patient, who is early symptomatic, ought she to favor, for example, saturated fats, especially animal fats, over unsaturated fats, as they become a much more, 30, 40, 50% of her calories?
So I want to say that, there's a big hullabaloo and buzz about coconut oil, and, coconut oil is now on every shelf in every supermarket in the country, and that's based on anecdotal evidence. The objective evidence is not as strong as the anecdotal evidence, it kind of follows the prescription medical food of Axona, which is a medium-chain triglyceride, and the idea is Axona can recapitulate what a prescription medical food can do. But the data in an objectively tried trial is not as robust as it has been for the medical food, and therefore I would say I would not routinely recommend it, but I do discuss it with my patients and say this is something that a lot of people are doing, although the data is not as robust as the medical arbiter called YouTube has led people to think is important.
Let's see. Of course, we actually are on YouTube, but that's okay. David, should she eat more foods with saturated fats than unsaturated? And if she should, ought they to be more of animal or vegetable origin, or does it matter?
Well, I don't know. The question, when you say more foods of one sort or another, I think it would be more relevant to talk about her percentage of calories that are derived from one food source versus another. And that's it. Let me just go back and comment about, and I'm in agreement that there is not robust data indicating interventional utilization of something like coconut oil. I think it's not really been studied, although the peer-reviewed literature goes back to the Vedic texts some 3,000 years ago, if you consider it peer-reviewed, where coconut oil was actually utilized in Ayurvedic medicine as a treatment for dementia. Who knew? But the point is, I think that it does recapitulate the action of axone in terms of elevating availability of beta-hydroxybutyrate and potentiating this ketogenic state to augment ATP production while reducing free radical formation. And from a mechanistic perspective, therefore, I'm okay and feel comfortable in utilizing coconut oil, which is far better tolerated than axone, in my opinion, and certainly much less expensive. So I use a lot of coconut oil. I don't have any problems with that. But what I do, and I'd be interested to hear other comments, is I generally titrate the use of, I hate to call it dosages because it's food, but the amount of coconut oil that my patients will take based upon their utilization of keto sticks, determining if they are mildly ketotic based upon testing their urine. It's certainly something that a lot of athletes do, a lot of weight loss people are involved in, so it's really, how to do that is actually very straightforward. Now, with respect to the monounsaturated resources like olive oil, I think there's a bigger story there than just the fact that olive oil is high in monounsaturates. And looking at the data with reference to olive oil, as we mentioned earlier, the recent study demonstrating it in addition to a Mediterranean diet. Because what we know is that there are other components of olive oil, the polyphenols, etc., that actually work on amplification of like the NRF2 pathway. So it's a really powerful epigenetic issue in terms of augmenting pathways that enhance free radical quenching, that reduce inflammation, and augment detoxification pathways like augmenting glutathione as transferase activity, for example. So I don't think that it's totally fair to judge, for example, olive oil just based upon the fact that it is a fat. And I think that we all agree that the type of fat people are consuming has a huge role to play in terms of health outcome. And that said, we're not talking about the comparison here between a standard high-fat American diet versus a low-fat, higher-carb diet. We're talking about the quality of fat. We're not suggesting a high animal-based fat diet coming from meat that's been fed genetically modified grain that's high in omega-6s that is pro-inflammatory. We're being very specific about the type of fat, the olive oil, the coconut oil, etc., that people are consuming.
Exactly right. I really like that point about olive oil being a much more complex substance than a monounsaturated fat. It has actually a little saturated fat in it. There's also evidence for mitochondrial action in olive oil, as well as vitamin solubility, particularly E, and to some extent B. And of course, olive oil is actually a fruit juice. It's not a fat because of the olives are a fruit. But it has a very strong anti-inflammatory component, which goes to both of your points. So final question before we wrap up. There is, as you know, Alzheimer's strikes the left side more than the right side of the brain, and you smell, your left side of your nose smells differently than the right side of your nose, and there's this peanut butter test where the right nostril is able to smell peanut butter 10 centimeters further away than the left nostril as a diagnostic test for early Alzheimer's disease. Is that test accurate for the early diagnosis of Alzheimer's disease for food as diagnostic instrument? And if not, is there something to this woman's early loss of smell that's characteristic in Alzheimer's disease?
So I will say to you that anosmia has been well documented as a early feature of Alzheimer's disease, and multiple companies for the last 15 years have been trying to develop diagnostic smell tests. So the peanut butter is just the latest in a number of trials and studies of diagnostic smell tests that have been developed. However, They all have very good sensitivity. They all can detect anosmic changes occurring early on. The problem has been across the board, peanut butter or otherwise, they have very low specificity, and they are challenged by trying to distinguish an anosmic profile of Alzheimer's versus an anosmic profile from other conditions, neurological or otherwise.
And anosmic means the inability to smell. David, do you agree there?
Oh, I completely agree. And I would say that, interestingly enough, in the setup, when you presented the case and you mentioned her issues with smell, how you went through the laboratory studies, and which are fairly standard laboratory studies that have been on the books for dementia for a long, long time. And I would indicate that there was absence on that list for things I think that are very relevant. First, I mean, you include the RPR. That's something everyone should check in patients suffering from dementia. When was the last time any of us saw a patient with neurosyphilis? On the other hand, when was the last time we saw somebody, for example, who had an elevated homocysteine, who had a suboptimal vitamin D level, who had an elevated hemoglobin A1C? And I would submit that in terms of diagnosis, or at least giving you ideas of things that are potentially treatable, that those would be far more relevant in a patient like this one presented them looking at things like the RPR, for example.
Really good point.
Agreed.
Wonderful point. Thank you so much for it. So there you have new specific suggested eating plans for early Alzheimer's and pre-symptomatic, and then different eating plans for pre-symptoms, and then an agreement about the importance of fat content for Alzheimer's disease that's early or even later. So that's the time we have today. For more information, please read our transcript and the references on food for Alzheimer's prevention at medpagetoday.com/culinaryrx. I want to thank Dr. Marwan Sabbagh and Dr. David Perlmutter. Please comment on this discussion and share it with your friends and colleagues, and ask your own doctor to write you a Culinary RX today. Thank you very much, gentlemen. Have a great day.
Thank
Thank you very much.
Very good.